There is a specific kind of anxiety that exists only in a sterile waiting room. You are sitting on a crinkly paper sheet, staring at a poster of the skeletal system, and you realize that in about 3 minutes, someone in a white coat is going to walk in and ask you a very simple question. What brings you in today? And suddenly, your mind goes blank. You know you hurt, but translating that physical sensation into precise language feels impossible.
It is a universal paralysis. We assume that because we inhabit our bodies, we should be experts at describing them. But medical communication is effectively a second language. There was a study published in the journal Health Communication that suggested a significant percentage of misdiagnoses stem not from medical error, but from communication breakdowns during that initial history-taking interview. If the patient cannot articulate the nuance between throbbing and stabbing, the doctor is working with an incomplete map.
That is the gap we need to bridge today. We are dissecting the linguistic toolkit required for a doctor's visit. This isn't just about vocabulary lists, it is about medical literacy and patient advocacy. We are going to move chronologically, from the initial appointment booking to the specific descriptors of pain, and finally to understanding the treatment plan. I want to start with the concept of triage, because this often happens before you even see the doctor.
The triage process is critical. When you call to make an appointment, you are usually speaking to a medical receptionist or a scheduler. Their job is to categorize the urgency of your condition. This is where many people falter. They either downplay their symptoms out of politeness, or they provide a vague narrative. The key here is specificity regarding time and severity. Phrases like acute onset, meaning it started suddenly, or persistent symptoms, meaning it hasn't gone away, are triggers for the scheduler.
People often use idioms here, which can be risky if not commonly understood, but some are standard. The user prompt mentioned under the weather, which is fine for casual conversation, but medically it is useless. If you tell a scheduler you are under the weather, they might book you for next week. If you say, I have a high fever and shortness of breath, you get seen today.
Precisely. You have to distinguish between a routine checkup and an urgent consultation. Once you are actually in the room, the dynamic shifts. The doctor is acting as a detective, and you are the primary witness. This brings us to the most complex part of medical English, the taxonomy of pain. Pain is subjective, but the words we use to describe it align with specific physiological causes. We cannot just say, it hurts.
Let's break down that taxonomy. The user's request highlighted the difference between a dull ache and a sharp pain, but physiologically, those two descriptors point to entirely different systems in the body, don't they?
They do. A dull ache is typically associated with musculoskeletal issues or chronic inflammation. It is diffuse. You cannot pinpoint it with one finger. If you tell a doctor you have a dull ache in your lower back, they are thinking about muscle strain or perhaps kidney issues. Contrast that with sharp or stabbing pain. This usually indicates something acute, a nerve being pinched, a tear, or an obstruction. If you describe the pain as stabbing, the doctor is looking for immediate mechanical causes.
We also need to discuss throbbing. That word evokes a very specific image, a pulse. Why is that distinction important for a diagnosis?
Because throbbing or pulsating pain is vascular. It means the pain is keeping time with your heartbeat. This is the hallmark of a migraine or an abscessed tooth where the blood pressure is exacerbating the nerve endings. If you use the word throbbing, you have effectively ruled out a simple muscle cramp. Another crucial descriptor is burning. A burning sensation rarely comes from a broken bone. It almost always signals a neuropathy, nerve damage, or a chemical reaction, like acid reflux.
The McGill Pain Questionnaire is worth mentioning here. Developed in the 1970s at McGill University, it was one of the first attempts to standardize this language. It groups words into sensory, affective, and evaluative categories. One of the words from that index that often confuses patients is radiating.
Radiating is vital. It describes pain that travels from a source to another location. The classic example is a heart attack, where pain originates in the chest but radiates down the left arm or up into the jaw. This is distinct from migratory pain, which moves from one joint to another. If a patient says, "My back hurts," that is one thing. If they say, "The pain starts in my lower back and shoots down my leg," that is the textbook definition of sciatica. The word shoots or radiates gives the doctor the diagnosis before they even touch you.
What about the intensity scale? We are all familiar with the 1 to 10 question. It feels incredibly arbitrary. My level 5 might be your level 8. How do we navigate that subjectivity effectively?
The numeric rating scale, or NRS, is flawed but standard. To make it useful, you have to anchor it with functional descriptions. A 10 isn't just really bad. A 10 is incapacitated, unconscious, or specifically, the worst pain imaginable. A better way to communicate intensity is to describe how it affects function. Instead of just saying, it's a 7, say, it is intense enough that I cannot sleep, or it prevents me from walking. Functional limitations are objective facts that doctors can use.
That connects to the vocabulary of severity. Words like excruciating or unbearable are emotive, but debilitating is clinical. Debilitating means it stops you from functioning. Let's pivot to symptoms that aren't pain-based. The sensation of the room spinning versus feeling lightheaded. People use dizzy for both, but they are medically distinct.
This is a classic triage trap. Lightheadedness is the feeling that you might faint, often caused by low blood pressure or dehydration. Vertigo is the sensation that the environment is moving around you, the spinning room. Vertigo suggests an inner ear problem or a neurological issue. If you tell a doctor you are dizzy, they have to spend 5 minutes figuring out which one you mean. Being precise, I feel like I'm going to pass out, versus the room is spinning, saves time and leads to faster imaging or treatment.
We should also touch on nausea. It is interesting that we have a noun for the feeling, nausea, and a verb for the action, vomiting, but people often mix the adjectives. You feel nauseous. There is also the concept of malaise.
Malaise is a fantastic, underused term. It describes a general feeling of discomfort, illness, or unease whose exact cause is difficult to identify. It is that under-the-weather feeling, but elevated to a clinical symptom. It often precedes the onset of a virus. Fever vocabulary is also specific. A low-grade fever is different from a spike. If you say, my fever broke, you are indicating the crisis point has passed and your temperature is returning to normal. These temporal markers help the doctor build a timeline of the illness.
Let's move to the physical examination. This is where the doctor starts giving instructions. Take a deep breath, cough, but they also look for tenderness. How is tenderness different from pain?
Tenderness is pain elicited by touch. If you have a headache, you have pain. If I press on your temple and it hurts more, that area is tender. This is a critical distinction in abdominal exams. You might not be in pain while sitting still, but if the doctor presses on your lower right quadrant and you jump, that is rebound tenderness, which is a classic sign of appendicitis. Reporting that it only hurts when I touch it changes the diagnostic pathway entirely.
Once the exam is over, we move to the diagnosis and plan. This is where the passive voice often takes over. You are being prescribed or you need to be referred. Let's talk about the difference between a chronic condition and an acute one. This confuses many patients.
Time is the variable. Acute means sudden onset and usually short duration. A broken bone, an asthma attack, the flu. Chronic means persistent and long-lasting, typically developing over time, like arthritis or diabetes. The treatment goals differ. Acute treatment aims for a cure. Chronic treatment aims for management. Understanding this helps manage expectations. You don't cure a chronic back condition, you manage the symptoms.
And the medication terminology. We have OTC, or over-the-counter, versus prescription. But the most important part here is dosage and adherence.
Adherence is the medical term for sticking to the plan. Non-adherence is a huge public health issue. When a doctor says, take this course of antibiotics until it is finished, and the patient stops because they feel better after 3 days, that is non-adherence. It leads to antibiotic resistance. Understanding the instruction, take with food or on an empty stomach, is biochemistry, not just a suggestion. Some drugs are absorbed too fast without food, causing toxicity. Others are blocked by food.
I want to circle back to the idea of prognosis. Patients often confuse this with diagnosis.
The diagnosis is the identification of the illness, the what. The prognosis is the forecast of the likely outcome, the what happens next. A patient might have a serious diagnosis but a good prognosis, meaning they are expected to recover fully. Asking, what is the prognosis, forces the doctor to explain the long-term outlook, which is often what the patient is actually worried about.
Let's synthesize this. The goal of this vocabulary, words like radiating, throbbing, vertigo, tenderness, prognosis, is to reduce the friction between what you feel and what the doctor understands. It empowers the patient.
It shifts the dynamic from passive recipient to active participant. If you walk in and say, I have an acute stabbing pain in my abdomen that radiates to my back, accompanied by nausea, you have essentially written the first paragraph of the doctor's chart for them.
You save time, you reduce the chance of diagnostic error, and you ensure your pain is taken seriously.
It is about precision. We often think of medicine as a science of biology, but in that consultation room, it's a science of language. If you can't describe it, they can't treat it. We've covered the booking, the pain descriptors, the systemic symptoms, and the treatment plan. It is a lot of terminology, but it's a toolkit you hopefully won't need often.
Exactly, but when you do need it, these words are clearer than any X-ray. They are the primary data. So pay attention to your body, articulate what you feel, and don't settle for "it just hurts."